uproar. Sjögren syndrome and Scleroderma. Now, Sjögren syndrome, although you may think that the most common presentation is that somebody has a dry mouth, in reality the most common presentation is people who have joint pain. Now that's not distinct though, that's not distinct. That's why people don't get the diagnosis just from joint pain, because a woman who's 45, 50, 60 years old presenting with some non-specific joint pain without obvious physical deformity is not something that will really stick out in your mind. Now, how to answer the question what's the most likely diagnosis is with the dry eyes and the dry mouth. And one of the major functions of saliva is keeping your teeth clean. So all your teeth rot out of your head if you don't have saliva. And that's why it is that you also lose taste and smell. Almost 2/3 of taste and smell have to do with having saliva in there to be able to moisturize it and get the taste particles off. If you have a dry mouth, you can't taste your food because the molecules of tastins can't reach your taste receptors. You lose those teeth because right now, anybody who's got a dry mouth teeth rot out of their head because you make 1 to 2 liters a day of saliva that washes off all that goopy stuff that keeps your teeth nice and clean. It's like a garden hose, hosing off your teeth. Yes. Now, diagnostic testing in Sjögren syndrome, the most accurate test is lip biopsy. That's the most accurate test. But the best initial test is to poke him in the eye. Oh my God, oh, your eyeballs are dry. Here, let me take a piece of paper. Does that hurt? Does that hurt? Come here, come here. Doink! And that's a very strange thing to do. Somebody says, doctor, my eyes are dry and they hurt. Really? Let's test it. Boink! Poke you in the eye with filter paper and see if you can't cry. Oh, I guess you're sick because you can't cry. And that's why, because a normal person should be able to wet the paper, and they can't. Decreased lacrimation. Remember though, the big issue is you can't have teeth with a dry mouth. Now, the serologic testing is not great. Now, which test is most likely to be positive? Which test is most likely to be positive in Sjögren syndrome? It's not what you think. It's not the SSA and the SSB. It's not the row and the lot and the lot and the row and the row and the lot and the lot and the row. It's the ANA. Yeah, but the reason it doesn't stick out in your mind is because even though it's there, 95% of patients, lots of things have a positive ANA, so it doesn't stick out in your mind. That's why. Rheumatoid factor doesn't stick out either because it's there in so many people. Just remember, a negative ANA has an extraordinarily high likelihood for excluding Sjögren's. Positive means nothing, but a negative ANA means highly unlikely to be Sjögren's. A negative ANA, unlikely to be Sjögren's. Rho and La is there in about half or 2/3. Now they're fairly specific. They're there in most people with Sjögren syndrome, a bunch of people with SLE, but remember they're not there all the time. That's why you end up with that lip biopsy. Your mouth is dry, you're anti-La, I'm anti-La. You pro-La, I'm not anti-La. So my mouth is dry. Well, if you're so anti-La, my vagina is dry too. Now the treatment, unfortunately we don't have a treatment to really cure Sjögren syndrome. Steroids do not work. Steroids are the most common wrong answer. You keep your eyes and your mouth moist. Which taste has the greatest production of saliva? Is it sweet? Is it salt? Is it sour? Is it sugary? Is it umami? What is umami? Umami is a special taste that happens in Thai kitchens, yes. But the greatest amount of saliva is produced by sour. Sour is the greatest amount of saliva. And you use pilocarpine, increase acetylcholine. And here's something special just for Sjögren syndrome. Cevimeline, that's special just for Sjögren syndrome, cevimeline. Cevimeline is an increased acetylcholine just for your salivary glands. Increased acetylcholine just for your salivary glands, cevimeline. Now, off to the next disorder. Oh, remember the other big question about Sjögren syndrome? The worst thing that can happen to your Sjögren syndrome, remember, is lymphoma. Now there are some oddball tests there of rose bengal in your eye, showing breakdown of your cornea, and also a decreased tear breakup time. Wow, you got an abnormal tear breakup time? Yeah, well, tears should be able to hold the shape. Did you know that? Ooh, that's the shape of my tears. Something very poetic in there. Okay? Alright, so but the thing is that you should be able to have tears that hold a shape, and they can't hold a shape in Sjögren's, rose Bengal, and also coelography of the salivary glands. Coelography, the ducts are abnormal. The ducts are abnormal, but the worst thing that happens is lymphoma. Don't answer steroids.
Cevimeline is specific to salivary glands. Pilocarpine inhibits acetylcholine esterase everywhere and increases acetylcholine everywhere. And that's why pilocarpine has much, much more on the adverse effect side. See, salivary glands massively increase secretions from acetylcholine stimulation, but we want something that's not going to have effects everywhere. If you've really ever spent time around people with severe myasthenia, you know that the biggest problem that they have is that they start having all sorts of adverse effects from the medications. Now, in this case, in Sjögren's syndrome, we just need the acetylcholine in one place. We need it just in the salivary glands, and that's your basic science correlate. Give me a muscarinic agonist that's specific just to salivary glands.
Scleroderma, okay, systemic sclerosis, tight fibrous scleroductily, thickening of skin, Raynaud's phenomena, red, white, and blue, blue, white, and red, blue, white, red, and blue. Okay, they treat that with calcium channel blockers. Joint pain, well, this is the rheumatology section, so I can expect a lot of joint pain for everything, you know? Now, the difference between diffuse scleroderma, between systemic sclerosis, and limited sclerosis is, one, the lung fibrosis. Lung fibrosis. Now, the pulmonary hypertension is from fibrosis. The pulmonary hypertension is from fibrosis. Okay, so that's not a primary pulmonary hypertension. That is not a primary pulmonary hypertension. That is not a primary pulmonary hypertension. A primary pulmonary hypertension means you got pulmonary hypertension with no lung fibrosis. The primary pulmonary hypertension can be seen in CREST. And that's one of the only interior manifestations of CREST. And that's one of the highest function questions. Man, if you're going to get that question, you're going to get like a 300. Maybe 305. Doesn't go up that high, but maybe it will. Because CREST has primary pulmonary hypertension, and diffuse scleroderma has pulmonary hypertension from lung fibrosis. And that is the leading cause of death. So you have to treat this with, get something special. Not steroids, but you use cyclophosphamide for that. Use cyclophosphamide for that. And you get chronic diverticuli, yes, esophageal, but esophageal dysmotility is with CREST as well. That's with CREST as well, reflux. And you get autoimmune diseases like primary biliary cirrhosis. But the other thing is diffuse sclerosis, systemic sclerosis. Diffuse systemic sclerosis has lung fibrosis, kidney fibrosis, heart. Lung, kidney, heart. Lung, kidney, heart. Lung, kidney, heart. What's the difference between diffuse scleroderma and CREST? Lung, kidney, and heart problem. Severe hypertension that can kill you with acute hypertensive crisis. Now, there are diagnostic testing, and the most specific test for scleroderma is the... No, not the ANA. Fooled ya! Another person with ANA! No, the top isomerase, also known as SCL70. SCL70. You like that, the paradox that? Scleroderma 70, anti-SCL70 is present in 30%. You like that? Anti-SCL70 is present in 30%. That's supposed to be a great test. 30% of patients? How ridiculous is that? So those are the tests there. So there's not much in the way of tests for scleroderma. You might say, well, how do you know it's there? You see it on biopsy, or you see it with the person with We don't have a treatment for this that's proven effective. Penicillamine is not a truly effective therapy for scleroderma. Penicillamine is not. You see that not? It's cap. Oh, there it is. Underline again. Underline. Red. No, not. The renal crisis with ACE inhibitors and pulmonary hypertension. Cyclophosphamide, bosentan. Bosentan is an endothelin-1 antagonist. Bosentan and ambrisentan is an endothelin-1 antagonist. Bosentan and ambrisentan are endothelin-1 antagonists. The prostacyclin analogs. Now let's not get those confused. Bosentan is an endothelin antagonist. Bosentan, ambrisentan. The prostacyclin drugs are epoprostenol, treprostinil, iloprost. Epoprostenol, treprostinil, iloprost. epoprostenol, treprostenol, iloprost. That's the prostacyclins. And of course, a little Viagra, you get to breathe better and have a pecker that's bigger too. How good is that? Calcium channel blockers are good, but they're not specific to the pulmonary artery. See, bosentan stops the growth of the pulmonary artery. Endothelin 1. Prostacyclin opens the pulmonary artery. Bosentan is an endothelin, and prostacyclins, epoprostenol, treprostenol, iloprost, and sildenafil, tadalafil, all of the other fills fill not only your penis, but your pulmonary artery. Now, Raynaud's is with calcium channel blockers. That's old, easy. And PPIs, you can't reverse it. What you do is just treat it symptomatically. Now, the cyclophosphamide is really important because that can be a life-saving drug. We don't have great stuff there. You'll be tempted to use steroids. Don't do it because it's not a neutrophil lymphocyte problem. It's just fibrosis. Now, CREST, or limited scleroderma, presents with just what the word says, is one of the great acronyms, and just say this, well, the C is the calcinosis, the R is the Raynaud's, blue, white, red, white, blue, red, pain, esophageal dysmotility, which gives me dysphagia, but most importantly, reflux, because my esophagus becomes now one big immobile tube. The esophagus becomes one big immobile tube. The esophagus becomes one big immobile tube. Sclerodactyly, and telangiectasias. Now, we don't have a specific treatment for either the calcinosis or the sclerodactyly. There's no answer to that question. We have no specific treatment for the cardiac fibrosis, none for the cardiac. We have ACE for the kidneys, cyclophosphamide for the lungs, and for the pulmonary hypertension, bosentan, the endothelin antagonist, prostacyclins, and Viagra. CREST presents with just this being only these manifestations, just in the acronym, and remember, primary pulmonary hypertension, but not joint pain. One of the few rheumatologic diseases with no joint pain, no heart pain, heart, that's why it's limited, because there's no heart, no lung, no kidney. That's the key question. No SCL70. Instead of SCL70, you get centromere, or I like to think of it as crestomere, helps you remember. Anti-centromere, anti-crestomere antibodies, anti-centromere. I'm going to get a job as a weatherman after this. Eosinophilic fasciitis is just what the word says. It's eosinophils in my fascia. Well, since the good news is, at least this gives you something to treat it with, right? Oh, I got eosinophils, let's give some steroids. I got eosinophils in my fascia, let's give some steroids. The other thing is this red-orange shape, the red-orange thickened skin with eosinophilia. Most accurate test is a biopsy, but what's not present, you don't have the Raynaud's, you don't have the hand involvement, you don't have all these systemic organs. It's just in the skin. It's also worse after exercise. You exercise and your eosinophils get mad at you. Orange peel skin and then your eosinophils get mad at you. Now the treatment is steroids, eosinophils, worse after exercise. And that's the end of that because that's what that word means, eosinophilic fasciitis. The skin becomes all thick and stuff, but biopsy, steroids, worse after exercise, orange peel. That's all you need to know. Those are the 4 questions.